Hi friends, welcome you all at Indian Institute of Learning Life Saving Skills. Today we are there with you to discuss the most important emergency topic where you need to clinically justify and take a judicious history before coming to any conclusion so that there shouldn't be any misdiagnosis. And the topic being how to differentiate in emergency about seizure and syncope. Seizure and syncope, these are a most important two terms where most commonly the patient presented with loss of consciousness, and sometimes the misdiagnosis of a syncope taken as a seizure and patient is continues to pop up the anti-epileptic drugs till he or she finds a clinical evaluating judicious physician clinician, and where the complete or proper history taken and the patient is exactly diagnosed to have syncope. So the most important, both these two events presented with loss of consciousness, and if the patient is taken to the some neuro department, and when the thorough history is not taken and not clinically evaluated, and sometimes the syncope is misdiagnosed as a seizure disorder and patient continues to have the anti-epileptic drugs till the diagnosis is made properly. Syncope and seizure, how to differentiate clinically? Both are presented with loss of consciousness. In syncope, usually we don't find the tongue bite. Most of the time there will be no loss of bladder or bowel movement, so there will be no incontinence of stool or urine. There will be no post-ictal phase. There will be no disorientation. There will be a transient loss of consciousness and patient regains the consciousness, and he will able to memorize all the things pre and post the event. But in case of seizure, the most important is there might be the tonic-clonic movements. There will be tonic-clonic movements, one thing. There will be amnesia, post-ictal phase, that we call as confusion, or sometimes patient will be disoriented. Most of the time or usually presented with the tongue bite and involuntarily loss of urine and fecal, that is stool and urine continence will be there when we are finding with the seizure disorder. Sometimes both of the patient usually have the common finding is loss of consciousness. If other part of the history is not taken, clinical examination is not done, sometimes the lab parameters also will be not going to reach on a proper conclusion. So what happens, the patient both will present with loss of consciousness, and when we are evaluating or taking the proper clinical examination, judicious history taking, then we are able to find out. So today we are going to discuss the most important case scenario where a 56-year-old male was presented with frequent episode of loss of consciousness. He was having the loss of consciousness, frequent episode. Then he was taken to some of the physician, or let us say neurophysician or neurosurgeon. Neurosurgeon evaluated the case and the case was diagnosed as seizure disorder, and patient was started with anti-epileptic drug. But even after starting the anti-epileptic drug, patient was continued to seize. So add-on therapy was made. The dose of the anti-epileptic drugs AED was increased, and add-on therapy, one more drug was add on with the previous drug, but still the patient was continued to seize. So that shows means it was not a seizure, because it was continued, patient was continued to the seize, or it was exactly a syncope. Then the patient was referred to or in emergency taken to some of the cardiologist, or where he was evaluated and find out some kind of arrhythmias due to some kind of blocks in the atrioventricular blocks. So this is how the patient presented with the common feature of loss of consciousness, and in both cases we find loss of consciousness as a common. And if we are failed to take the judicious history taking clinical examination, now in these dilemmas what to do? The basic investigation has to be carried out, like complete blood count, sodium, electrolyte, sodium, potassium, calcium, magnesium level has to be done, And other than this, we have to get it in the MRI brain if it is not contraindicated. MRI brain with seizure protocol followed by ECG. ECG and EEG both are important. Electrocardiogram and electroencephalogram both are having its own importance, because sometimes these syncopal episodes are of what is of not of because of seizure, it are because of the cardiovascular events. Most in 20% of cases it is because of the cardiovascular events that leads to the syncopal episode, and that are mistaken as the seizure disorder, so this is most important. So in this we have to, sometimes what happens when patient comes in the emergency, ECG might be normal. At that time the patient brought to the emergency department or triage, there might be ECG might be normal, because it is an episodic phenomena. That phenomena has happened few minutes back, and when the patient has reached to the hospital, that time what happened, ECG may be normal. So that requires the continuous monitoring of electrocardiography, sometimes need admission and evaluation for the patient. So this is a case was discussed just to find out, like when patient comes with loss of consciousness, that doesn't mean always it is a seizure disorder. It could be because of cardiovascular event. So always remember, all LOCs are not because of neurological event, it might be because of cardiovascular event. So thank you very much for watching this. So let us connect with us for more of the clinical information with Indian Institute of Learning Life Saving Skills. Thank you.